Good morning. Hi, this is Babak, Larian, and I'm doing a Facebook live session on salivary gland and parotid issues. I'm going to start actually by talking about the salivary glands themselves, just the brief descriptors, because Mary had questions about atrophied parotid glands. So I'm going to go ahead and talk on that one subject. Let me flip this around. Here we go. So, all right. So, salivary glands are obviously very important, and let's move back to the previous slide. There are multiple glands in the salivary glands. Let me actually transition you to a different program where we can see this better. So, you have the parotid gland, which is the biggest of the salivary glands, even though it only produces 10% of the saliva, right? Each parotid gland produces 10%, so the two of them together produce 20% of the saliva that you have. Then there's the submandibular gland down here, right? That each of them produce 25% of your saliva. So the two submandibular glands produce 50% of the saliva that you make. There's sublingual glands right there, right? Those produce a certain percentage as well. And then inside the lining of the mouth, in your cheeks, on the inside of your lips, on the back of your throat, on the palate, in your throat, all around, there's salivary glands that are tiny little glands. So when you look on the inner side of your lip, and you see those little bumps on the inside, those are salivary glands. Each one singular independent salivary gland. And each of those salivary glands are producing saliva independently of the bigger glands. So there's a lot of saliva being produced on a constant basis. We make 2 liters of saliva a day. So if you imagine one of those big soda bottles, right, the huge soda bottles, that's how much saliva we're making each day. And the purpose of that obviously is to lubricate the food and allow the swallowing. It's there to begin the digestive process. And we're also there to decrease the amount of bacteria in your mouth. So it constantly washes away the bacteria in your mouth, and as you swallow it down, so that it creates a balance essentially in your mouth that's necessary for normal function. I'm explaining the salivary function to answer Mary's question, and then I'll move on to some of the tumor questions that are coming up. In any case, so going back, the way saliva functions is that there is a flow of saliva from the ducts of these glands. So you can see, let me actually do it in a different color here. This is the duct for the parotid gland. This is the duct for the submandibular gland, and then the sublingual gland will do in blue, which has multiple ducts in it going onto the mouth, right? And as saliva flows, it gets to the mouth. This constant flow of saliva from the gland also prevents bacteria from going backwards into the gland and causing infections. So a constant flow of saliva is necessary for normal function, okay? Since the glands are making 2 liters of saliva, if a person is in a situation where they're not hydrating well enough, the saliva that they would make would get a little bit thicker and stickier and can get stuck in the gland. And when it gets stuck in the gland and there's less flow through the ducts, the bacteria can move backwards into the gland and cause the gland to get infected, swell up, and become uncomfortable. That's called sialoadenitis, or infection of the salivary glands. When it's in the parotid, we call it parotitis, which can happen more commonly than the other glands. We find this happening commonly in the elderly because the thirst centers in our brain start to deteriorate at the age of 50. So by the time we're 80, we're not very good at telling when we're thirsty or not. And if we're not in the habit of drinking a lot, we may get into trouble and get dehydrated without realizing, and you have saliva production that's minimized, and thus the glands get infected, right? Now Mary asked I have atrophied parotid glands, right? So atrophy means shrinkage of the parotid glands. Shrinkage of the parotid glands usually happens when the gland is not functioning, right? So if you have blockage of a duct, let me flip you around here. If you have a stone, let's see. All right, so the program is not doing its job, but let's see. Let's try it one more time. Oh, sorry. Here we go. So, here we go again. Let's repeat that down here. If you have some sediment forming in the gland because things are thicker and they come together and coalesce and come together and become a stone, then when they accumulate here in the duct, they block the movement of saliva, backs up in the gland, and the gland gets bigger and bigger and infected and so on, right? But if you have blockage of the ductal system, that usually happens because you have sediment forming in your gland because your saliva is thicker. So hydration is key. In the past, most of the people who were younger and were getting salivary gland infections were because they were having surgery and not getting hydrated well. During surgery or afterwards, that would get it. And it happens in the elderly, but it can happen at any age if you're not hydrating well enough, okay? So the functioning of the gland is completely dependent on movement. Now, if you have a stone like this, right, and saliva keeps getting backed up in the gland and causing infections in the gland, over time the gland loses its normal functioning and stops working. And because our body works on maximal efficiency, if something is not working, your body doesn't want to spend energy on it, and in time the gland can shrivel up. So that's one reason glands can become non-functional and shrink, Mary, is because if there's blockage preventing them from working, and over time they stop working and they shrivel up. Another thing that can do it is an autoimmune attack. So if your immune system by mistake thinks your salivary glands are something foreign and attacks them, then those glands over time after each attack will function less and less. At first people tend to get infections, and over time they atrophy and become smaller. So those are the main reasons one can have salivary glands that are shrinking, or parotid glands that are shrinking, okay? Hopefully that helps, Mary. Now, moving on to tumor questions. Jane Schuster has a question, I think looks like a long question, so let me read it for you guys. Jane writes, I have a question. I was diagnosed with a right parotid carcinoma X pleomorphic adenoma, size 3.1 centimeter, classified as stage 2. So pleomorphic adenoma, which is the most common benign tumor of the salivary glands, which is the most common tumor of the parotid gland, unfortunately has a genetic base to it that has the potential of transforming and becoming a cancer. And the cancer is called carcinoma X pleomorphic adenoma, meaning it used to be a pleomorphic adenoma, and now it has become a carcinoma. Adenoma is for benign tumors, carcinoma is for cancerous tumors, right? So the adenoma became a carcinoma. And that tends to happen about, the incidence is 10% at 15 years, and it continues to grow thereafter, right? So unfortunately, Jane had that transformation. So it was a stage 2, 3.1 centimeters, with a comment on the pathology report of the tumor being moderate to poorly differentiated, with some areas showing features of salivary ductal carcinoma. Invasion is limited. So when this pleomorphic adenoma, and it's called pleomorphic because it has multiple forms. Pleo means multiple. Multiple forms of salivary tissue are inside this tumor. So it's not a singular type of cell inside of it. It's multiple different types of cells in a single tumor, which is very interesting in and of itself. But when they become cancers, they can become multiple different types of cancers. Salivary ductal carcinoma is one form of it, is a little bit more aggressive form. There is also myoepithelial carcinoma version of it, which is a little bit less aggressive form of a cancer. And so, Jane, you had a relatively complicated and aggressive type of transformation. Okay. Now moving on, with a fair amount of complications after surgery, had 3 surgeries and 33 radiation treatments with 3 additional high-dose radiation treatments. No lymph node involvement or invasion. Left with trigeminal neuralgia. This was in 2013. All my doctors have left for other hospitals across the country or leaving medical field for other pursuits. How long should I follow? How long should I be followed, and by whom? I'm still having issues with fatigue, swallowing. Today was told it's been so long since my cancer, I should be fine. Not that I'm a negative person, I just a realist. Once you have cancer, you always have cancer. Was how I thought about it prior to my diagnosis. Let me explain. So, cancer develops because a singular cell somewhere in your body, in your particular case, in your benign tumor, the singular cell transformed and lost its control. Because it lost its control, it could duplicate and get bigger at any rate it wanted. It can, and as it duplicates and gets bigger, each cell, when it duplicates, it copies 30 million genes, right, and gives it to the new cell. That process of copying can have errors in it, and those errors, majority of times, are detrimental to the baby cell, and the baby cell dies. But sometimes those baby cells have an error that loses another control, which allows it to become more capable of doing things. So if there's less control, it can do more things, meaning it has to have these genetic changes before it can go to other parts of the body and metastasize, right? So this process of growth and duplication is what allows more changes, which allows the cell to become more aggressive, right? So your tumor had those changes, but fortunately never got to the point of metastasizing to the other parts of the body. In that you had a very aggressive version of this transformation, right, to the salivary ductal version. Those tumors are very aggressive and very unforgiving, meaning that they don't lie dormant, right? This particular flavor of parotid cancer is not the type that lies dormant. If it's there, it grows rapidly, right? And when it grows rapidly, you can see it. You can visibly see the change, right? So if after 5 years, so with my patients who have salivary ductal carcinoma, or a carcinoma explomorphic that has transformed to salivary ductal carcinoma, such as yours, once we get to a 5-year mark after treatment is completed, after radiation is completed, and they have not had a recurrence, I have never seen these patients get a recurrence, because when you do the surgery, you remove the pleomorphic adenoma, the benign tumor that this came from, and a large portion of parotid around it, right? And then you radiate that area so that just in case there was any kind of cancer cells left behind around the area where you did surgery, the radiation would capture it. If radiation and surgery was not able to capture these cells, and there was a cell that was still alive, within those first 5 years, that cell would grow large enough to manifest itself and show itself. Because this is an aggressive, rapidly growing cancer. Now, if you had a less aggressive cancer, or a cancer that is slower in its growth processes, right? Or a cancer cell that needs triggers to start its growth processes, right? So sometimes some breast cancers can recur after 10, 15 years. Thyroid cancer can come back after 15, 20 years, right? So, those tumors are different. But your version of a tumor is not one that sits around idle. It grows quickly. Okay, so I would say that being that your tumor was treated in 2013 and you are now 6 years away from it, at this point, we're not worried about you having a recurrence of your cancer, right? But you have had complications, so let me read on. No one ever really explained this type of cancer. I only know what research I was able to read online. Can you point me to the direction to follow? I mean, there are some articles out there that tell you about the different types of cancers that carcinoma explomorphic can be, right? And they describe the different variations. I was actually involved with a textbook that I wrote about pleomorphic adenomas, and their conversion is being talked about on another chapter. It should be coming out by the end of the year, hopefully, and that would be a good resource. But there are articles out there. I did some research and saw some of the articles that show this. But more importantly, I just need you to know that after 5 years, the chance of you having a tumor come back is exceedingly low to non-existent. And I can't say ever zero, but close to it, 99.99%. Because I haven't seen it certainly happen in these aggressive cancers, okay, fortunately. Now moving on, do I find new doctors to follow me or just follow up with my PCP? Last question is, what is the recurrence rate of this type of cancer? The recurrence rate is fairly high, but that happens within the first 5 years, right? Most of those recurrences happen actually within the first 2 years. And as time goes on, the chance of recurrence becomes less, and when the recurrences occur, they're usually slower growing tumors and less aggressive. And so when you have a recurrence at 4 years, that is a less rapidly growing tumor, less aggressive, we are more able to remove that tumor and cure that person at that point. So the chances are low and close to non-existent for you at 6 years out. Let's see. Sorry, there was a phone call. How long should I be followed? By who? I still having issues with fatigue, swallowing. All right. Since you're having issues with swallowing, still, I think an ear, nose, and throat doctor should follow you for the swallowing problem. While they're following you for swallowing problem, they can easily check your parotid gland. So whenever you meet with them, they can follow that. But an ENT doctor is the right choice of doctor to be following you. They're the ones who are going to have most expertise dealing with this issue. But I'm concerned about the fact that you still have fatigue 6 years later, especially if you didn't have chemotherapy, all right? So you should have an endocrinologist do a full workup, or your primary doctor look at your hormones, look at all the vitamins, or all the things that are involved. If you had radiation to this area, you need to look at your thyroid, make sure your thyroid function has not been affected by the radiation, and so look at the hormonal balance of your body as well. But an ENT for sure, for the swallowing and potentially the parotid itself, although purely for the cancer thing, it's not necessary for this kind of cancer, okay? And for the fatigue, I would say your primary doctor or an endocrinologist should look into it for you. Okay, dear? Jane, tough situation. I'm glad you've survived despite this, and I wish you the best. And you write at the end that I talk too much. I'm windy, and you know, when you have this kind of a complicated situation, I don't think what you're writing is too winded, my dear. All right, moving on to Sue Van Tienen Keech. Hello, Sue. Hopefully I didn't insult the way I said your name. Hello from Canada. We was supposed to have third surgery to remove these things. Now they want to do MRI every 6 months to watch for growth. Said another surgery, I would lose bottom half of my face. What causes the stones to form in the ducts? Let's see. So, can these tumors affect someone's voice or the loss of? All right. So let me just kind of pursue. I'm assuming you have a benign tumor. That's why they want to watch it. All right. So if you're having a benign tumor that has recurred multiple times, means during the first surgery they were not able to remove the entire tumor. Some small pieces were left behind, right? And that pretty much usually happens in what pleomorphic adenoma, the most common tumor that this occurs in, because pleomorphic adenomas have little legs. If this is the tumor, there may be little legs on them like this sticking out, and so if you do the surgery and amputate a portion of these legs, those little amputees or amputated portions will grow in time and become multiple other tumors, right? So if during the first surgery that happens, you never know how many pieces are left behind. So when you had the second surgery and they took out what visibly looked like recurrence of tumor and potentially a little bit larger, if they missed some of the other amputated portions that were left behind because they didn't see it, then they would recur again, which is what leads to that third surgery, right? Or the recurrence that you're having currently. I think, Sue, this is a question that's complicated to answer, but I'll do my best to answer it for you. if you have a pleomorphic adenoma, and that's why the recurrence is happening, right? The only reason for you to want to do the surgery is because you're concerned that these tiny little tumors have the potential of becoming and transforming into a cancer, just like what Jane experienced, a carcinoma pleomorphic. The chance of that, again, is 10% at 15 years, right? And if you're at your third surgery, I'm assuming you've had these for a long time. So that's the concern. So what you have to do is assess the risks that you're dealing with, right? The risks are, one, to proceed with surgery and risk getting injury to the facial nerve. Although I've done this surgery a third, fourth, even a fifth time on patients who've had surgery elsewhere, and the facial nerve injury rate has been very low, but it's still a real risk, right? So you have to consider that risk and compare it to the risk of it becoming potentially cancerous in the future, and put your age into consideration and state of health. The reason I say this is if the person who is in your scenario is an 85-year-old man who has heart disease and lung disease and multiple other medical issues, then I would say don't do surgery. Monitor it, follow it up, because your life expectancy is not tremendously long, right? And you have multiple other issues. Having surgery may affect your other conditions, so the risk benefit ratio balances in favor of monitoring than doing surgery. If, on the other hand, you're 40 years old, you have no medical issues, you have these things, you've had them for 20 years now, they're in place, you're young, then I would say you should do surgery. Because you're young, you have a long life ahead of you, and the potential for transformation is much more because you have a long life ahead, and there's a chance of the opportunity for transformation is much more, and so it should be done. And I would say if you choose the path of surgery, right, do it with someone who has expertise, a lot of expertise, so the chance of facial nerve injury becomes less. And subsequent to your surgery, you may consider doing radiation, because there still may be more small little pieces left behind that are not visible currently, and with the radiation you can potentially stop them from growing or developing, okay? So that's one. The other question was about loss of voice. No, these tumors cannot cause any voice loss. They're too far away from the voice box, and they're too far away from the nerves that go to your voice box that move the vocal cords. So most likely not the source of voice issues. And then you also asked what forms stones. Stone formation usually is either there's a genetic base to it, or it's because of not hydrating enough and allowing sedimentation to form in the glands. That, as far as we know at this point in time. All right. So, Lara Malik, hi doctor. Last year I had adenoma pleomorpho surgery. Now sometimes that side of the face swells, jawline under the cheek. Is this normal? It is not normal, but it could happen if during the surgery, let me flip you around here. So when you looked at the duct of the gland here, this is the duct going into the parotid gland. When the duct comes in the gland, it divides into multiple branches, and those divide into multiple other branches, right? So if the tumor that you had, we'll do the tumor in green, was here, and in the process of removing it, they removed this, then this duct here and this duct there no longer are connected to the main ducts, and the saliva that comes into them has nowhere to go, so it backs up in the gland, and that portion of the gland would swell up, right? Very uncommon for this to happen, but it does happen at times, and so that's potentially the reason for you to get swelling. What I would suggest is that you have your surgeon that did the surgery look at your gland, look at the flow of saliva from that parotid gland, from the duct of the gland in your mouth by looking in your mouth and pushing on the gland and seeing how much flow you have to assess whether a portion of the gland is swelling or all of it, and potentially even do imaging to see if there is an area where there's a fluid collection in the parotid gland, which would clue you in as to which portion of the gland is blocked. But having said that, the treatment for that is hydrating a lot, so I would suggest drinking more water for now to see if that affects it. And if it doesn't, the only other alternative is to do surgery. And you have to ask yourself, is it worthwhile? If this symptom is bad enough that you would do surgery for it. You also write that your ENT has left the hospital in the past 6 months, so you don't know where to go. Lara, you really need to find another ear, nose, and throat doctor if you feel like you need to address this. Now, you also should have this tumor assessed. You know, the pathology report is really what's crucial. If the pleomorphic adenoma that was removed was clear in all directions, let me flip this around. So if the tumor that was removed, you have margins around it, and on the pathology report says the closest margin is 5 millimeters away, then the chance of recurrence is exceedingly low. If they say the margins are positive, meaning that instead of having a salivary tissue around it, it was close to it, right? Or the tumor comes to the edge, then the chance of recurrence is higher. And so based on that, you need follow-up. And so the pathology report is important in letting you know how to address this. Okay? Best of luck, my friend. You do need to find another ENT. Okay, so Sue says first surgery was 2005, second one 2016, and then 2017 is now when the other one has happened. I'm 54 with multiple issues. I have Dr. Gulain. Dr. Gulain is good. I know him only by reputation, so that, you know, take that with a grain of salt. Okay. Radiation has been discussed. I would not do radiation, Sue, without doing surgery, because if you have a large enough lump of tumor that's visible on imaging or by feeling, then that may be a little bit too big for radiation to dispose of. You really need to do radiation for microscopic pieces, or at least that's what we know to be, based on the research that's been done and the articles published. It's the microscopic disease that can be addressed with radiation, not larger type disease. So I would say radiation as backup after surgery if you choose to go path of surgery. 54 is young, but if you're having medical issues, you may want to wait and monitor until your medical issues are more stabilized, and then at that point reassess. But you're in a tough situation, and I understand that. If medical issues are so overwhelming at this point, monitoring would be an appropriate choice. Hopefully that can help you, Sue. Okay. Imad Milan. Hello, doctor. I'm from Algeria. Since February 2012, I've now removed parotid for the third time after surgery of 2008 and 2012. And this is for fear of facial disability. That's okay. What should I do? Because I want treatment in Europe and they did not allow me to leave the country. I mean, Imad, you're kind of stuck. You need to find the most experienced surgeon in Algeria to do your surgery. Okay? And again, based on what I told Sue, the choice for the third surgery has to do with the pathology of tumor. So if you have a pleomorphic adenoma, your concern is that it's going to recur. But if it's a cancer, then you really have no choice. You have to do the surgery. So if it's benign, you have the option of monitoring. If it's not benign, you have to have surgery, of course. So that's really the key point. And best of luck, Imad. I know it's a tough situation. I have relatives in Iran, and they have medical issues. It becomes very tough because some can be handled very well in Iran, and some just cannot, and they just don't have the luxury or the option. So I feel for you, my friend. Question, Kea Monroe. Does radiation cause parotid tumors? I work as a dental assistant. Kea, yes. The only known causes of tumors in the parotid gland are radiation exposure and genetic predisposition. I'm sure there's more reasons that we just don't know what they are. Probably hormones and preservatives and all the toxins that are now in our environment and smog and so on and so forth all contribute to it. But yet radiation is. Now, dentists are very good at protecting themselves against the radiation exposure. And usually, the way they have it set up is that the machine is in the room, and the person who's doing the x-ray leaves the room to push the button, or stands far enough away where they're not exposed to that radiation. So you should be safe if the dentist is following the protocols that are necessary to protect you. All right, but it's good that you have this in your head and you're concerned. Both, all tumors can occur with radiation exposure, in all sites, specifically parotid and the thyroid. And that's why dentists put the thyroid shield when they're doing dental X-rays on the patient. But if you are concerned, you may want to get some of those protections for yourself and wear them as you're doing your work. All right. Sue writes, I waited 7 months for a date, then they decided they will monitor growth. I think, Sue, again, monitoring for growth is not a bad way, especially if you have other medical issues. Having said that, you said that the lower division is at risk. Lower division's main function is to bring the lower lip down when you smile, right? So for someone who has a big smile like this and all the lower teeth show, it's very meaningful. For someone who has a upper lip smile, not quite as meaningful. And I keep telling people that when they lose the lower division, they have a Sylvester Stallone smile, Adrian, because the lower lip on one side moves, on the other side doesn't move. So it's not obviously ideal, but it's not a huge deficit either. Okay, so kind of keep that in mind. I'm not telling you to do surgery or not. I'm just giving you the information so you're better able to decide. Imad Milan, is this time late because the tumor was not? No, I mean, again, Imad, you're not telling me what kind of tumor you have, so it's hard for me to know. If you can tell me what type of tumor it is, I can better answer you. Rob Joseph, hi doctor, does tumor extend to the inked surgical margin on final histology the same as a positive margin? Yes. Does this increase the risk of recurrence of a polymorphic adenoma? Yes, it does. Not a lot, but it does. All right. So usually when I have someone who has completely negative margin, right, then I have them do an MRI at 5 years or 7, 8 years to see if there's a recurrence. If on the other hand they have a positive margin, I try to encourage them to get an MRI at 1 year and then again at 5 years. And the reason I do the 1 year mark is not because I expect them to return, but because at the 1 year mark, I want to see what things look like, so that if something shows up at 5 years, if I know that it was there at 1 year and hasn't changed in size, then more than likely that's a scar, not a tumor, right? And so that's what I would suggest for you. There was one spot that was close to the marginal mandibular branch, and that's the part that didn't have as much normal tissue excised. Rob, I'd say probably 80 to 90% of the patient tumors that I remove in the parotid gland are sitting on one branch of the nerve or more, right? And I do anywhere between 2 to 5 of these surgeries a week. And in all the years that I've been doing this and taking all these tumors out, despite that closeness of the margin, I have not had, I've had only one patient have a recurrence. So despite that closeness, the recurrence rate is low. It's just something that you have to keep in mind. All right, that seems to end all the questions. It's always a pleasure and an honor to be able to do this and to be able to reach people all over the world, from Canada to Algeria. It's really amazing that this platform exists and that can be done. And I'm so glad to be able to help. I wish the best for all of you. Best of luck. And oh, Desiree Cantrell just came up with a question. I'm 2 months post-op from having a pleomorphic adenoma removed, and I am still experiencing a small amount of paralysis in my upper lip. Can I expect it to come back? Desiree, if your upper lip is moving a little bit, then more than likely it'll come back fully. If it's not moving, then I wouldn't be able to answer you, because I would have to know what happened during surgery. But if your surgeon says that the nerve was fully intact and they stimulated it and the lip moved with them stimulating it, then more than likely it will come back. But if you have partial movement already, then it probably will come back. All right, very good. That ends it, I think. All the best to all of you. Take good care. Bye.